A 340B covered entity is allowed to purchase a drug at a discount in accordance with the law.
Yes.
Hospitals then create savings by charging commercial payers and Medicare at the same rate they would be reimbursed had they purchased it through either commercial payer or through Medicare.
Yes.
Commercial insurance reimburses at a higher rate than Medicare.
Yes.
Medicare typically pays higher rates than Medicaid.
Yes.
So a hospital generates revenue from the 340B program by purchasing the drug at a highly discounted price than getting reimbursed by the payer, like a commercial health plan or Medicare, at the higher rate of what they would bill the payer as if it bought the drug at the regular commercial price.
Yes.
As I've always understood it, and I think you said this too, the savings from this are what covered entities are supposed to use for health care for underserved patients. Would you agree with that?
Yes.
All right. Now, hopefully we didn't put everybody watching at home to sleep with that, but I did think it was important that we get that out on the table. Dr. Smith, Medicare beneficiaries are required to pay a 20% cost sharing for Part B items and services. Drugs administered by covered entities, hospitals, in-outpatient departments are covered by Part B. Do Medicare beneficiaries pay their 20% cost sharing based off the acquisition price of the drug, or do they pay their 20% cost sharing as if the covered entity bought the drug at the regular price?
I would say generally they pay as if the covered entity bought the drug at the regular price.
Okay. And hypothetically, if you had Hospital A that had a pay mix of 90% public and uninsured patient and only 10% commercial pay, versus Hospital B that had a payer mix of 50% commercial and 50% public or uninsured, which hospital would be able to generate more revenue from the 340B program?
The hospital with more commercial patients, for sure.
And could you please explain?
Well, again, as I said in my testimony, the way revenue is generated through this program is the hospitals arbitrage the discount. They buy it low, and then they sell it high to a commercial insurer, to Medicare, or to other payers. And that's how they generate revenue. That's arbitrage. That's the classic Wall Street arbitrage.
And so basically, if you have a 50% mix of commercial payers, what's going to happen is that you're able to get a lot more money out of that because you're charging those commercial insurance companies for the full freight and not actually having to pay.
Yes, and that's one of the misaligned incentives in the program, in my view, is that hospitals tend to want to bring in more patients with good insurance, and that's
Right.
that's not the legislative intent of the program.
As opposed to going into underserved areas where they can't get as much. All right. Dr. Giorgio, and I think that's what happened with Bon Secours in Richmond.
Absolutely.
Dr. Giorgio, the facility you work for or work in provides care for a large number of low-income and uninsured patients, nearly 80%, as you stated in your testimony. There are patients the 340B program is and should be specifically targeted to. The part of Don McEachin's district that the New York Times reported on is an economically stressed area, which I imagine is similar to the patients you serve. Can you elaborate on how the 340B program is needed to keep your doors open and how important the program is for you?
Yeah, low-income patients simply, they take more resources to care for. These patients lack basic social support networks. They lack access to basic things like nutrition and transportation. They have much extended hospital length of stay because they don't have the support networks to safely discharge them. So these patients take just a lot more resources to care for. And when you're a hospital like mine that predominantly serves these patients, it simply takes more resources to care for them.
And if a wealthy hospital with large share of commercial patients use the program, does that negatively impact you all?
It does in that they are turfing patients to us that should be treated by that program. So they're given this large discount, and then they send the patients to us anyway.
And one final question. If you move the patient or if you move the services completely out of Richmond and you move it, say, 8 to 10 miles away, a lot of those underserved patients can't get there, can they?
Right. Most of them lack basic transportation.
So they're not going to be able to go get the services even if they're still somewhere in the area.
That's correct.
And that's sometimes what happens. I yield back.